Thank you, Axel. Good morning, everybody. It's my honor to be here today chairing this session. I think we have a lot of exciting scientific talks to hear today, and hopefully everyone in the room will get a lot of new information. Our first speaker today is Dr. David Sugarbaker, not to be confused from his brother Paul, who's also here in the room. Dr. Sugarbaker is the Richard E. Wilson Professor of Surgical Oncology at Harvard University and the Chief of the Division of Thoracic Surgery at Brigham and Women's Hospital. He's well known for his surgical advances in this disease and particularly for his use of intrapleural chemotherapy. So without further ado, Dr. Sugarbaker.
Thanks very much, Lee. It's a real pleasure to be here with all of you, families in particular, who know exactly how this disease works, how it marches on in many cases. But I think we're having some significant improvements in the overall outlook for patients and families. And I say patients and families because this is a disease that affects everyone in the family. It's not simply the patient's problem, it's everybody's issue. And we recognize that, and therefore the good news applies to everyone, families as well as patients. So I'd like to talk to you a little bit today about our experience with intraoperative chemotherapy and kind of why we're doing it. And there's been a lot of controversy, as to which operation you should do for pleural mesothelioma. And basically the goal of any type of surgical procedure is cytoreduction. Macroscopic complete resection. The idea here today would be to talk a little bit about the importance of macroscopic complete resection by one or the other operation. And those of you who've been to our program know that we offer both depending upon what's best for the patient. Heated intraoperative chemotherapy basically to extend the surgical margin because we know that 80% of pleural mesothelioma comes out adjacent to where it was removed. So the idea is how can we take out everything we can see and then extend our margin by 2 or 3 millimeters. I tell the residents we're a millimeter or 2 from a cure in mesothelioma. Systemic cytoprotection, so as to allow us to give very, very high doses. In other words, cytoprotection, protecting the cells from the chemotherapy, the normal cells. I'm going to just review our first decade of experience and where we're going from here. So, macroscopic complete resection is the goal. We want to move beyond all the arguments and discussions of surgeons about what operation do we do, pleural resection or take the lung out, extrapleural lumpectomy. Which one do we do? It's really a moot point. Let's move on. Because when you look at other cancers, breast cancer, for instance, surgeons used to think that you were curing it with surgery, with what was called mastectomy, where you take out all the lymph nodes. If they're positive, well, you've gotten them out. But we now know that unless you get, that even with an R0 resection, which means no disease left behind, that there was systemic disease already in the patient and that cells are circulating. Some of the more recent data of filtering of blood shows tumor cells circulating in the blood in almost every solid tumor that's removed. Well, pleural mesothelioma is the same drill. We go for a macroscopic complete resection, and our target now needs to be microscopic residual disease. So the goal of mesothelioma surgery at the present time in the pleura is to optimize macroscopic cytoreduction, pleurectomy decortication, and our work has been particularly focused on extrapleural pneumonectomy because that was the procedure that really gave us the first long-term survivors back in the late 80s. We've refined the technique, we've reduced operative mortality to that of other comparable procedures, lobectomy, pneumonectomy for lung cancer, 1 to 3% mortality. So macroscopic complete resection by either operation is feasible. This is really what we found from 1988 to 1999. These are the conclusions that I think we established as part of the acceptable platform to move forward. Long-term survival is possible. Now that seems maybe taken for granted at this standpoint, but when we started, all the survival curves were in weeks or days with mesothelioma. Nothing seemed to be working. completely remove all the tumor you can see, and long-term survival began to manifest itself. We found out that certain cell types are better, that node status is important. We developed a staging system which we published, which has been now the sort of appropriate focus of a lot of discussion. Let's get people discussing staging. Primodality therapy, which we produced as the first treatment strategy, removal, additional chemotherapy and radiation, became the paradigm internationally. And most importantly, we found that local failure, that is to say, the disease coming back locally, was the primary barrier to long-term survival. And that was really illustrated in this paper by my colleague, Dr. Baldini, who followed a number of patients in our clinic and found basically that future strategies should investigate methods of enhancing local control. That the abdomen, the chest where we took it out, were the primary sites where we were losing the battle. Where were these cells coming from? From the pleural surface, from being sort of spread around at the time of surgery, despite our best efforts, and also tumor at the margins of removal in the muscle, in the chest wall, in the abdomen. So we want to extend the surgical margin with heated intraoperative chemotherapy. The drugs basically go by direct diffusion, you know, just by the concentration of the drug. We don't need to use the intravenous system. We get good tissue penetration, which we've measured. And we have an advantage from the standpoint of pharmacokinetics. We have a much higher concentration in the bath, and it's diffusing all the time into the patient. So we've wanted to establish feasibility, they find out what dose we should use, because nobody could tell us what dose to use, and no one else was doing it. We wanted to see what toxicity profile, where were the drugs going to manifest their own toxicity, because every chemotherapy drug, as you know, has toxicity. And we want to investigate where things go. And this, I don't know, I guess, do you have over there, can you click on that for me? Maybe not. Can you put the cursor on that just to put the where is it? Not around? Okay, click. Can you try clicking? Not working? Okay, that's fine. That's all right. So basically what we want to do first of all is to extend the margin. That just shows the heated chemotherapy at the time of surgery in the operating room. It takes 1 hour. After you've removed the specimen, then you wash for 1 hour. Systemic cytoprotection. How do we protect the normal cells? There's this drug called sodium thiosulfate that we give right after the lavage to clear out primarily the cisplatin. And what we do is to do the extrapleural pneumonectomy. This is really a timeline. The extrapleural pneumonectomy is done usually in about 1.5 hours. And then 1 hour of hyperthermic cisplatin with sodium thiosulfate. Our first one was to do it this way. And I'm just going to move through here. Here is the overall survival of the first group that we did with a single drug. We had about a 15 to 20% 5-year survival. And you can see in this group that the higher the dose, the more people, the longer they lived. We then did a group of patients who could not undergo a extrapleural pneumonectomy. So we did a pleurectomy decortication. And you can see here, again, hyperthermic platinum. We increased the dose every 3 patients to find out what the maximal tolerated dose was. We published this in the Journal of Clinical Oncology. And basically, here's one of the most exciting curves I've seen in a long time. And that is at the lower dose, because we had to do this by the Institutional Review Board, making us start low because they were worried about toxicity. But as we increased the dose, patients did much better here in the yellow than the red. And I'm going to move through this, but basically the second drug we used for systemic cytoprotection to protect the normal cells as we escalate this dose of chemotherapy is amifostine. And it binds to normal cells, protecting them from the protection of the cisplatin that's absorbed into the blood. So we did this particular one with the extrapleural pneumonectomy, hyperthermic platinum, but we give the amifostine ahead of time.
Yeah, I don't know.
And we published it, and the results are seen here. I'm just going to show you here's the overall survival of early stage disease, 40% 4-year survival. So So we're beginning to make progress. With a single drug, platinum and amifostine, we're now seeing a 40% 4-year survival in early stage disease. Now we wanted to look at the amifostine with an extrafluorodemenectomy. That was the previous one with fluorectomy decortication. So here we are protecting the patient from the platinum, the normal cells. And again, this was published several years ago. As you can see, the mortality was 4.3%. That's essentially the same as pneumonectomy and lobectomy when you look at the national data. And what you see here is in this phase 2 trial, a 32% survival for early stage disease. And that to us was extremely encouraging because our survivals now are between 30 and 40% at 3 to 4 years with the use of these meds. And it's up substantially from our 18 to 25 months survival that you have read in our previous publications 15 years ago. So if you look at HIAP, the first decade of experience, our early trial summary, we've established a new platform for the treatment of mesothelioma of the chest. You know, we now have a platform of intraoperative chemotherapy that may seem like an automatic, but many people were skeptical that we could do an extrafluorodemenectomy or fluorectomy decortication, in some hands a 3 to 5 hour operation, and then do an hour of chemotherapy and then close, or reconstruct maybe the diaphragm and pericardium afterward. And so we established it based on the data I just showed you and published that you can do it with a 3 or 4% optimal mortality. That hyperthermic lavage is feasible. Other people said, well look, if you bathe that thing in chemotherapy, your sutures are going to come loose. And bad things are going to happen. That's why another reason we stepped up slowly on the dose. But we found that we could do it and do it safely. We could get 2 to 3 times the dose of platinum right at the tumor site that we could ever give intravenous. It would be way too toxic. That the optimal timing was a combination of the 2 agents formulated. And that we saw dose-related survival, which is one of Hill's postulates, which establishes the efficacy or the vitality of the treatment. So we then decided to move into double drugs, to give an additional drug. And gemcitabine was a drug we used because it's compatible with platinum. The toxicity to the patient doesn't overlap. You know, so we don't get an overlapping toxicity. Gemcitabine profile is quite different than platinum. And yet there's been a number of studies showing good efficacy of platinum and gemcitabine in the primary treatment of mesothelioma patients when given intravenously. Some people think it's comparable to alembic. And the intercavitary pharmacokinetics were favorable, and so we went with the gemcitabine platinum. The last thing I want to talk to you about is this trial. This is what we call a schema. I'm sure you've seen them earlier in this meeting. Patients have a diagnosis, they get one or the other, extrafluorodemenectomy or fluorectomy. Because remember, all we're interested in is macroscopic complete resection. One operation and the other operation, they're not interchangeable, they're not comparable. Fluorectomy decortication is for early stage disease, and later stage when the tumor is invading the lung, extrafluorodemenectomy is in order. We then give amifostine, we then do intracavitary platinum, and dose escalation of gemcitabine, and then we're giving thiosulfate at the end. So now we're using 2 drugs to protect the patient in order to get a higher concentration of drug during the lavage, because we know that the dose-related effect has been established, at least suggested by these studies. So we enrolled 114 patients to date, 109 patients were eligible. This is a prospective trial run through the Dana-Farber Clinical Trials Office. And the mean age was 66. A little more than half were epithelial. And that tells you that about half are what we call the mixed tumors, you know, much more difficult to treat for many patients. So 74% were resectable. The extrafluorodemenectomy PD was 40% or 30%, so more of these were EPP slightly than the fluorectomy. Median length of stay in the hospital was 12 days. We had a mortality of 1.8% in this prospective trial, and the median follow-up is 21.5 months. Now I'm going to show you what we call an interim analysis. This isn't the final. This is an interim analysis based on the low dose versus the high dose. And what you see here is that survival by resectability, all the patients that could have their tumor resected had median survival of 20.2 months. This is with an intent to treat calculation. I'm sorry, with the time of the surgery is when the starting point is on this graph. Unresectable was 11.4 months, which is about the same as the Olympic Platinum trial, which I think was about 12 months. And that's for the unresectable, because all these patients did get good chemotherapy when possible as an alternative to the fact that they couldn't have surgery. Now, when you look at survival by histology, it breaks out pretty much the same. Epithelial, 47 patients. The median survival of this group has not been reached, and they're running about 50% overall survival. Papillary, which was only 2. I put this on here just to show everybody that we are breaking out papillary tumors, which tend to act much differently and be amenable to surgical resection or simple observation. So we broke these out, but what you're looking at on this is approximately a 50% survival with median survival, meaning it hasn't started to dip downward. So the median survival has yet to be reached. The median survival for these 25 patients with mixed tumors was 17 months. And that's really one of the best in the literature for mixed mesothelioma. And the sarcomatoid, which is much more difficult to treat, remained at 7 months. Now, this is the most exciting slide for me, and it's an interim analysis. It's early. But what you see here is all patients with epithelial tumors, okay, who got the high dose have a better, almost a 90% survival with the median not reached at 21.5 months. Now, I've been at this for a long time. I've never seen anything approaching a 90% survival at 21 months. So we're very encouraged by this. And we're hotly pursuing this. And as you can see, we're now running at the 1,100 milligram dose. When you look back, you wish you could have given everybody that dose. But the oncologist will tell you here that, you got to go up the ladder so you don't hurt anybody with the treatment. That's what the IRB is there for. So I'll leave you with this slide, which I think is really encouraging. There's a bright light in my mind, and there's other interesting therapies coming along, biologic treatments, adoptive immunotherapy. We were just talking this morning. There's other areas too that I'm really looking forward to maybe add to surgery or add to chemotherapy in some way or another. When you look at the non-epithelial tumors, and this is the really tough nut to crack, you can see that the median survival it doesn't really follow by dose. Here's the higher dose in the red, and the blue is the lower dose. And actually, the lower dose appears to do better, but there's only 16 patients in one arm and 15 in the other arm. So where are we going in the future? Where are we going to take the foundational surgery, which leaves the patient with no tumor to be seen? That's where you want to start, in my estimation. What additional therapies can we give now to hopefully extend survival? If not, maybe ring the bell, as I know that's what MARF's all about, and that's what we're all about at the International Mesothelioma Program in Boston. So we have new agents and combinations coming along: platinum and pemetrexed, rapamycin, its effects on platinum. We had been looking at extreme drug resistance, but the company we were working with went out of business. Oncotech, we were trying to culture cells and find out which drugs would be the most appropriate. But, we'll work around that. Bidirectional chemotherapy, giving intravenous chemotherapy. I know the guys in the belly are doing that. And we're looking at exploring that as well. Taking out a lung is, I think, a little different maybe in some ways, although I don't want to insult the abdominal surgeons in any way, but you have to be a little bit more careful about fluid and myocardial protection and so forth, or you can get into real trouble. And then the personalized selection of agents with genomics. So in conclusion, I want to leave all you good people with a few conclusions. Number one, I think macroscopic resection is an essential component to the multimodality strategy for MPM. Not every patient can have surgery of one kind or another, but I think it's great if you can do it. Prevention of local regional failure is the goal of current strategies to extend survival. Local regional means the chest where it came out and the belly. Heated intraoperative chemotherapy has been established, I think, through our work and now the work at Pittsburgh and others who have now come along in a similar protocol. It's established as a new treatment platform, along with intravenous chemo, radiation. We now have intraoperative chemotherapy. Future directions will involve improved patient and drug selection. You've heard a lot about that at this conference. Combinations of drugs and methods for enhancing drug delivery and efficacy. We're working on the use of an oxygenator to highly oxygenate the perfusate as it goes around and around. The idea to prevent tumor cells from becoming what we call hypoxic, or having a want for oxygen and going into a dormant state called G0. So we're looking at some other ways to enhance the activity of the drug while the patient is asleep, and so that's really where we're going. This is the International Mesothelioma Program. I just want to thank really the whole staff that works in the program, our surgery, medical oncology, pathology, I mean the whole group, including our family support group that many of you may be somewhat acquainted with. So that's all I got. I'd like to thank the organizers of MARF for inviting me to come. Thank you very much.